Good afternoon and welcome. My name is Kirsten Jensen, and I am the Director of the Division of Benefits and Coverage at CMS. I am joined today by several of my colleagues, including Michael Tankersley, Cherie Gaskins, Melissa Misato, Ryan Tisdale, Marlena Thieler, and Michelle Weller. Thank you for participating today. As you are aware, the Centers for Medicare and Medicaid Services has scheduled 4 listening sessions centered on non-emergency medical transportation. These listening sessions have been set up so that CMS can gather your ideas on how we can improve non-emergency medical transportation services for Medicaid beneficiaries, with an emphasis on improvements to program integrity. CMS will not be making any presentations today or answering questions, nor will our facilitation partner, MITRE. The purpose of these sessions is to hear from you, and we encourage you to share your ideas and experiences with us. We will review all the input we get in our series of listening sessions and consider it when making updates to federal policy and operations. I want to emphasize here that we are discussing NEMT, not non-emergency transportation as authorized through 1915C waivers. So please limit your discussion to non-emergency medical transportation. Under Section 209B3 of the Consolidated Appropriations Act 2021, Division CC, Title II, CMS was directed to convene stakeholder engagement meetings to facilitate discussions on shared learning about the leading practices for improving Medicaid program integrity within NEMT services. CMS is very interested in your input on identifying the ongoing challenges to Medicaid program integrity, as well as the leading practices to address these challenges. MITRE is facilitating these listening sessions on behalf of CMS. MITRE operates the Health Federally Funded Research and Development Center for CMS. I would now like to hand this session over to Jeff Goldman from MITRE, who is facilitating today's listening session.
Thank you, Kirsten. This is Jeff Goldman with MITRE. I too would like to welcome everyone that has joined today's listening session. The purpose of today's session is to gather your input related to economic factors and cost containment challenges in NEMT or non-emergency medical transportation. As Kirsten mentioned, there will not be any presentations by CMS or by MITRE, nor will there be any question and answer period during this session. We very much want to hear your ideas on how CMS can make improvements to the NEMT program through federal policy or federal operational changes. Before we begin, I have a few housekeeping notes. Please be aware that this meeting is being recorded. By remaining in this meeting, you are consenting to being recorded. All chat comments will also be captured. For any press that have joined today's call, we kindly ask that you please remember to communicate through cms.gov/newsroom. A reminder that if you have any technical questions or difficulties, please reach out directly to Devon Parks with moderated service either via the Zoom chat or via email at devon.parks@cms.hhs.gov. That email will be placed in the chat. All participants will be muted throughout the listening session and until called on by the moderator, Devon Parks. Please note that once the moderator calls on you and announces that you are unmuted, you will also then have to unmute yourself to speak. You can provide input on NEMT leading practices and challenges in 2 ways: raise your hand feature or the chat. To verbally provide comments in this session, you use the raise hand feature. On the bottom of your screen, of your Zoom window, you will see a raise hand icon. Click the raise hand icon. You will then be placed into the queue, and when it's your turn to speak, you will be called. And it will be announced that you are unmuted by the moderator. Then you may also have to unmute yourself in order to speak. Today's session is broken into 7 sections. The first is for general comments on today's topic, economic factors and cost containment in NEMT. That section will be followed by 6 subtopics. Please note that you don't have to wait for the subtopics. If you have a comment to make, you can make any comments in the general comment period. We will stay on the general topic until the queue is emptied, at which time we will move to the subtopics as remaining time allows. You are encouraged to raise your virtual hand to offer comment or to respond to other comments in any or all of the sections. You may also use the chat function for your input. Please provide any written feedback that you have to the chat function. Due to the large volume of participants in today's session, we ask that you keep your comments to 2 minutes or less. We would like to prioritize the open phone lines for new comments. We encourage you to share your support for other participants' comments by using the chat feature. Comments will be selected in the order in which hands are raised. We will try to get through all participants in the allotted time, so please keep your responses concise and unique. We may decide to ask for specific comments on one of the subtopics if we have not heard anything related to that subtopic. Your participation in this listening session is voluntary. There will be no individual benefit from your participation, nor will there be any negative effects if you decide you do not want to participate. We would like to hear your honest input about the topics. There are no right or wrong responses to the topics. We encourage you to speak openly and honestly. You can choose not to respond to a specific topic or subtopic. You can also end your participation in the discussion at any time. We have allotted up to 75 minutes for this discussion. Again, today's session is focused on economic factors and cost containment challenges in NEMT, or non-emergency medical transportation. A reminder that we ask participants to keep comments under 2 minutes when you are called on, to allow for as many people to speak as possible. Now, we will open the session for discussion and comments. Again, we will start with a general topic, which is encompassing of all of the main topic and subtopics on economic factors and cost containment challenges in NEMT. Please begin by join the queue by raising your hand to share your comments. Thank you. And Devon will then call on folks in the queue as they arrive. Thank you.
Dan Reed, you've been unmuted.
Thank you very much, and I appreciate the opportunity to talk. States often issue an RFP calling for a single level of service for any MT trips, those as to encourage brokers into submitting lower price bids, for example, curb to curb only trips, but then demand service level requirements that go far beyond that specified in the RFP. An example would be a contract that stipulates all trips are curb to curb, but then requires a transportation provider to assist the beneficiary with a mobility device or greet the beneficiary at the door because the beneficiary is vision impaired or hearing impaired, for example. These latter requirements for assistance go beyond the curb to curb level of service dictated in the given example for an RFP issued by a state or broker contract. NEMT's Compliance and Regulatory Advisory Board recently completed a project to define levels of service. In doing so, the NEMT Advisory Board recognized the need for defined levels of service beyond just curb to curb, door to door, and door through door by creating new service levels of curb to curb with assistance, hand to hand, and transfer services. In setting these additional levels of service, NEMT recognized that far too many passengers require more than just transportation, i.e. they need some level of assistance, whether it's assisting with a device, assisting the passenger into or out of the vehicle, or providing assistance to and from the vehicle, but not necessarily all the way to the door. Additionally, NEMT identified those trips which required specific handoff and chain of custody documentation for passengers, such as for passengers unable to be left on their own and or children traveling alone. Finally, the transfer services line of service recognizes that NEMT providers can, in some cases, provide assistance to non-ambulatory passengers needing to transfer to and from a bed to a stretcher or mobility device. It's important that CMS stress to states that they adhere to either the level of services in their RFP or open their RMPs to acknowledge the fact that they are going to require levels of service beyond just, for example, curb to curb. Thank you very much for your time.
Luann, you've been unmuted.
Okay, you can hear me?
Yes.
Okay. I believe that there needs to be different levels of transportation options for our people. Some are higher functioning and don't need all the help. Also, I believe that in most of the government package that we get, there is money for transportation, but that money only can be accessed if they go to a workshop. And I know the DHHS mission for the year is to get more of these special people employed, but how do you get them there? In my example, my son cannot use local transportation because it doesn't go to, he works outside the area. He lives inside the area for local transportation, but then he goes outside the area, can't be used. So if CMS would free up, like for my son, the 5,000 that is in his package that we could access to use to pay my husband or myself to do all this running, or when we're not available, a friend. We do use some caregivers, but also I think you need to look into partnering with Uber and Lyft for the higher functioning young people or people that can handle an app and that, so that we can access that 5,000 or however much each package gets for, and be able to use that to help with transportation. The local transportation is so far behind in how you have to schedule. There's no apps, nothing like that. And so DHHS and CSM need to free up some of that money so that we can have access to it, so we can use it how we need it. And that's all. Thank you.
Robert Gallardi.
Yes, well, a majority of the time, the direct payments to beneficiaries and families is used as it's intended, which is to ease the transportation burden for a beneficiary to get to their appointment. There are some beneficiaries who use the non-emergency transportation providers as a backup reservation in case the family or friend or family member fails to or is unable to show up for the transportation. In these instances, the non-emergency medical transportation provider is left with a non-revenue trip when they show up to perform the transportation and the beneficiary is already left with a friend or family member. If the non-emergency medical transportation provider, perhaps because of repeated occurrences, suspects the beneficiary is using this tactic and simply doesn't go out to perform the trip, and it's an instance where the friend or family member cannot transport the beneficiary, then the non-emergency medical transportation provider is considered a transportation no-show. Rules should be in place that require a certain number of days in advance notice for a member to select the family or member or friend option if the trip has been scheduled with the non-emergency medical transportation provider, thus allowing the broker time to make sure to give the provider adequate notice of cancellation. Failure to provide or notice in the required fashion would not prohibit the beneficiary from riding with the family friend, but it would disqualify them from being reimbursed. At that point, the amount that would have been paid could then be paid to the non-emergency medical transportation provider, as compensation for the late cancel or no-show. This should cut down on double booking or backup booking of trips. While this may seem easy in practice, it only works if the brokers are required to have systems in place that provide double booking of trips for beneficiary and then actually have controls in place to ensure call center agents adhere to these rules. Brokers should also be required to track the use of friend or family member option to ascertain beneficiaries are using this option for the positive outcomes for which it was intended. That's all I have. Thank you.
Clark, you've been unmuted.
Thank you and good afternoon. I appreciate this opportunity. I'd like to speak to the subtopic of conflict of interest. CMS needs to do a complete review and overhaul of the entire broker model and develop standards for implementation that states must follow. There may have been a time when the resources required for a state to adequately monitor the quality and service of NEMT providers throughout their statewide program were beyond the capabilities of a state Medicaid agency. However, due to advances in technology, as well as some very clear failures that have been baked in the traditional broker model, those days have passed. The lack of transparency in the state-broker relationship creates an inherent conflict of risk. As has been stated throughout these calls over the past few weeks, brokers rarely disclose in real terms how quality is even factored into their allocation of trips within their NEMT provider network. Brokers will make claims that they only contract with high-quality NEMT providers. Therefore, quality is equal among all providers in the network. However, comments made over the past few weeks fail to support this claim, which in reality gives brokers an excuse for equalizing, therefore discounting, quality as a factor in trip allocation and placing a disproportionate weight on sending trips to the lowest cost provider. History has proven throughout all industries that rarely does the lowest cost provider meet the same standards for quality as other players in the industry. The argument that state regulatory agencies contract for curb-to-curb services because they have a financial and fiduciary obligation to obtain the lowest cost of service from a broker completely ignores several fundamental factors, such as the well-documented cost incurred by a state's healthcare system from beneficiaries not getting to medical appointments. States cannot truly say they accepted the lowest cost bid unless they are considering, and not just conceptually, but mathematically, the cost of key factors. This includes a broker's historic ability to provide on-time service and the cost of beneficiaries not getting to a medical appointment. The very real costs of missed appointments will often exceed any potential cost savings from accepting a low-cost bid from a broker who is unable to provide the required level of services to all beneficiaries. This places an extraordinary burden on the state's healthcare system from what should have been avoidable, but now necessary, medical procedures. For example, consider the cost of hospitalization for a beneficiary from medical services that would have been unnecessary had a state's NEMT contract provided for enhanced services to be contracted and paid for when deemed necessary. For the sake of the beneficiaries, quality must count. Providers must, in very real, transparent, and tangible ways, be compensated for quality service, instead of having to struggle to provide high quality service as a low cost provider. The conflict of interest created where a broker's profit margin can benefit from contracting with the lowest cost provider without having to account for the very real future cost to the state from the accompanying low quality service must be avoided. Again, thank you for the opportunity.
Celia Roman.
Oh, actually, this is Amber Irish. I signed in underneath Celia. She sent me the invite. Completely agree with the previous gentleman's statements about the model of the broker is very detrimental both to transportation providers, but also to the members. There's a lot of mismanagement of information, and as seen in the previous discussions, people using NEMT as backup service rather than as their primary source of transportation because their trips are either canceled, no-showed, not, especially here in Idaho where I'm located. We have over 30 to 40% cancellation rate, double booking, mismanagement of information. So a lot of times we'll preempt and cancel a trip because this person's canceled multiple times, not knowing that there's other factors and mismanagement of information that's happening. So I do agree that the brokerage model is outdated. There's not much going on in terms of managing cancellations. And I'd love to see us really focus in on that because it's hard to be a high quality provider when you're facing such a high cancellation rate. To the other point, I think that would actually move to that model would be, you were talking about direct pay to the providers and the lack of technical abilities of the NEMT companies, or by not funneling that through a brokerage system, that would be a nice pilot program. If the technology could be available to allow families and providers to book directly using an app to use those funds for other sources of transportation other than medical as well. That would get them into a seamless process and kind of avoid the brokerage model.
Casey, you can unmute yourself.
Thank you. I'm Casey Buderi. I'm here with the Medical Transportation Access Coalition, or MTAC. Thanks for the opportunity to comment again today. The topic is timely as the NEMT marketplace is facing considerable economic headwinds, and these include provider network challenges, which have long been an issue, but especially in recent months due to COVID-related workforce challenges and the material increase in gas prices, which affect many different MTAC members. MTAC members, including brokers, provider and managed care plans, continually strive for ways to improve efficiency and respond to market economic pressures in ways that don't disrupt access. For example, they may encourage family member mileage reimbursement or deploy advanced GPS technologies to more efficiently dispatch drivers. Nevertheless, it's important to note that brokers and managed care plans and their role in delivering NEMT benefits are constrained in their ability to respond to these challenges through increased payment to providers by the capitated rates that they receive from the state or from the MCO. Some Medicaid providers and MCOs do have risk corridors or other risk mitigation tools in their contracts that can protect against unforeseeable cost increases, while brokers generally do not, which limits their ability to provide mid-year assistance to vehicle operators. I'll also touch on a couple of the subtopics. First, broker conflict of interest and self-referral. These are essential for ensuring program integrity. A key tenet of the NEMT broker model is that the transportation service is provided at the most appropriate and lowest cost alternative. The self-referral provision ensures that a manager does not refer services to a transportation provider at a higher level of service in which it has a financial interest. As in similar physician cases involving self-referral, it would be difficult for a state Medicaid agency to detect if brokers that also provide transportation could possibly be billing for services that did not occur, or there were other program integrity issues within that self-referral. Appropriately, the current regulations allow for flexibility to address specific circumstances. For example, there are exceptions for a non-governmental broker that provided transportation in a rural area when there was no other qualified provider available. And then finally, NEMT with beneficiaries. NEMT for beneficiaries with challenging behaviors. Drivers need the ability to identify and flag dangerous behavior, and Medicaid programs need to work with brokers, MCOs, and providers when a beneficiary has been flagged as posing a legitimate threat. But it's important that these occasions are rare and don't devolve into patient dumping, which would undermine the goals of the NEMT benefit and the Medicaid program. Thank you again for the opportunity to comment.
Jackie? Harbert? We can't hear you. You're unmuted. Actually, we still can't hear you. So I guess you have to put your question in the chat.
While we wait for that caller to figure out how to get unmuted to be able to speak, want to make sure others know that the floor is still open for comments on the general topic or any of the subtopics. So we'll hold a few more minutes and see if there are additional comments on the broad general topic. Thank you.
Jonathan?
Hello, everybody. Jonathan Anthon with ISI Technology, the makers of Route Genie. I'd like to talk about a couple topics. The first being the per member per month reimbursement model, or PMPM as it is known. For those of you that might not be aware of that model, and for some state systems or even some MCOs, a broker is compensated a flat rate per member, per active member in the plan for each month. So if there are 10,000 members that are active for that month, that broker is reimbursed $500,000. If there are 1,000 members, that broker would be reimbursed $50,000. And that is regardless of how many trips are taken and what the cost of those trips is. So that reimbursement rate is flat. This model provides a strong financial incentive for brokers to do a few things that have an adverse impact on the overall level of service for NEMT. The first being encouraging the broker to book levels of service that do not adequately support the passenger to save a little bit of money. Second is to tend to lean too heavily towards the low-cost provider, was mentioned by some other folks earlier on. And the third is, unfortunately, to find ways to make it difficult or find ways to even avoid payments to NEMT providers for services that they have provided. I have personally spoken with both folks that have left brokers that work on this model, as well as some that even currently work for brokers in this model. And some of the practices that I've heard about and the intentional decisions that are being made by these brokers are certainly not things that will positively impact the deliverability of quality service. So I call upon CMS to perform a study in states with MCOs with a PMPM model. I believe if that study is properly conducted, I'm very confident that you will find lower average reimbursement rates to providers, more reports of provider no-shows because the broker is less likely to pay a premium for a higher level of service trip, a trip with excessive deadhead mileage, or a short notice trip. A higher frequency of unpaid trips or claims to brokers, and overall lower member satisfaction with the NEMT program. The second topic I would like to touch on is kind of more confirmation of rides. So EVV rolled out in the home care world nationally from a Medicaid perspective years ago. It's disappointing that transportation is behind. We over the last handful of years, 5-6 years now, we're starting to see states beginning to require what is often called digitization, or brokers to capture real-time trip data, often things like GPS or pick up and drop off arrival timestamps to confirm that rides are indeed being performed as the provider is saying they're being performed. Which is great. Hopefully that can become a national standard, and there can be a national standard as to what that actually means to make it easier on providers to meet that standard. This should also be some sort of requirement for anything for like gas reimbursements, direct payments to beneficiaries' family, even volunteer drivers, et cetera, or even if public transit passes are being offered, which they are in some case. Now, this doesn't have to include advanced technology. Obviously, many recipients are not smartphone users that using an app isn't a viable solution. But using an app isn't required by the EVV program for home care either. Some options could include matching transport and medical claims for a date of service, and matching the address, obviously, to the medical provider that was on the transportation claim. A mobile device on site at Medicaid providers, where the member could essentially confirm that they are there with some sort of PIN, or even maybe a phone call from the site of provider, very similar to how home care providers use an EVV system. I believe putting tools like this in place could both not put an undue burden on the recipients or the providers, but could certainly curb fraud, waste, and abuse in the industry. Thank you for the time.
Tom Gibbs.
Yes, I want to touch on 3 topics. One of them is going to be kind of a general topic, but let me talk about challenging behavior. We have situations where we will be requested to transport an ambulatory patient with challenging behavior. And while on the surface, we process that. When we pick them up, sometimes we discover that we can't put them in a sedan, or we can't put them with other riders, because they will unbuckle and try and have confrontations with some of the other passengers. So when we tell them, well, look, you're going to have the whole vehicle, and we're going to have to charge accordingly because we got a single passenger in a full vehicle, that causes some difficulties, and they just as soon not transport, or they make us transport under less than ideal conditions for some of the folks with challenging behavior. Most of these would be, some of the mentally challenged folks are the ones that have been deemed incompetent, but they're still ambulatory. Typically, like we had a wound on his foot, but he hasn't been deemed incompetent, but he would not ride with Uber. Uber refused to take him because he would get violent with the drivers. And so they called us, and we found we had to put him in the back of the van all by himself, as far away from the drivers we could, just so that we had time to react in case he got unruly. So we need to be able to bill more for circumstances where they're going to be the sole rider in a vehicle that would typically take more than one passenger, or have the right to reject that person. The other thing is in regards to wait times. There are often situations where we have to wait, and there is no easy way to bill for wait times. And that becomes sort of a difficult challenge if we leave and say, call us when you're ready, and they call us 20 minutes later. They don't oftentimes know if it's going to be 15 minutes later, an hour late. So that provides some challenges, because we don't really have any way to say, well, you're going to be billed in quarter-hour increments or half-hour increments. We've gotten rejected when we try and bill for wait times because it's not acceptable as a charge. The other thing that I want to cover is more general, and I'm going to say nationally the policy is the same, but geographically it might be different. But here where I am, I'm in Alabama, EMS does a lot of routine non-emergency medical transports. They don't like it. It ties up their assets. They're frustrated with it. But some of the reasons that has happened is because Medicare and CMS does not recognize wheelchair transport as a payable benefit. So the patient calls their insurance company or looks at their coverage, and it says, well, if I call an ambulance, it's covered. My EMS folks would love to figure out how to sub these out to me, but they don't have any way of knowing. There's no system in place where they can pick up the phone and say, look, we need you to do a wheelchair transport to dialysis. They don't know how to bill it. They don't know how to get that segregated into, dispatches out on their call. There's no system in place for that. So it's frustrating to them. It's frustrating to us. And Medicare is spending a fortune on routine medical transports being used by ambulances. I mean, you obviously know the rates are going to be hugely different. So we need to start talking about how we bring about some change to work with EMS, or make it mandatory for EMS to reach out to a wheelchair company or a non-emergency medical transport that you don't need an ambulance service. There needs to be some way for them to be able to check to see what's available and then sub that out. It's a suggestion for everybody in the nation, but here it's a real problem. The ambulances sometimes have to leave patients 3, 4, 5 hours at a time because they get diverted onto an actual emergency. And that call has already been booked and that transportation has already been booked. So everybody gets pretty frustrated. Thank you.
Celia again.
This is actually Lamar. Sorry, we're all logged in.
Okay.
So I apologize ahead of time. But I wanted to just speak on a couple small topics. I won't make it long at all. One was centralized credentialing. I know that it's not exactly mentioned in here, but it has a lot to do with the way that everything is set up, of course, the structure. A few years back, Medix had developed what we call ecosystem. So ecosystem was a product that basically divided the brokers from the providers from the drivers, basically forming a data highway. And that data highway had trips that were basically put in by all the brokers who were at the top. It didn't matter what they were, and had the brokers basically in this POC competing against themselves for rates. In other words, they were challenging each other because that's how their rates were being pulled by the providers that were in the lower half of the network, who were giving it out to the drivers who live with the standards. So it basically platformed everybody in a position that they were competing against each other, brokers against brokers, drivers with the same standards, the same initial software. And the way we developed it is that it was API adaptable to every single software that's out there, and every single broker can plug into it. So it was net neutral, and it didn't have anything with anything. The highway was basically given to CMS. We were testing it here in Houston to actually see how it worked. The ride pickups on this testing that we were doing with MTM at the time were under 15 minutes, okay? And it left the platform to actually pay drivers in real time, considering that this market is now part of the gig economy, but it's not part of the gig economy. So you got drivers out there expected to get paid. It said they're waiting 45 days, 2 weeks to get paid from their people. The provider is waiting 45 days to get paid for a broker on something that could be validated and verified and paid the actual next day. So we were able to actually take from this system and bill in 24 hours and have them paid with a third party that validated all the stuff. Now, it did require us to use some biometric verification and so forth to make sure all the validations were there so that it couldn't be frauded. But we put this system in place, and to date, haven't used it except in a POC. And we were kind of just looking at the idea, like, if it's there and it exists, is that it fixes 90% of the problems that you guys are presenting out there. And we're just wondering why no one's even speaking about it, even though they all know it exists. So that was one of my things that I was looking at just to speak to you guys on. And then it's not me or Medix that did it. We partnered with some of the best in the business, Mixed Technologies, BioKey, Lakeway Mobility. So the higher standard of services can be determined by having the right people to determine that these people need better treatment by sending them out with the transport. The first person to touch a client is the driver. They actually know more about it. They talk to the people there. So we don't understand why the system is working from the top to the bottom instead of from the bottom to the top, when according to the system, it says that the most important is the quality of care for the member. So when does the member get the quality of care that they rightfully deserve? And we're promoting technology, education, and training for people, just straight education. So we would like to see these things implemented in there, and it's literally as soon as possible. I think it should be something that's mandated, and at least something that's looked at to what's built already, instead of trying to rebuild and remap everything and change the entire structure or anything. Look at what's out there. We've been working diligently on this for over 5 years to fix a problem that no one's fixed, and still keep net neutral so that no one was losing in the process. I think that it warrants take a look at. Let's look at it and see, what does it solve for? What does ecosystem actually fix in these solutions? And from what I'm looking at, it's 90% of the problems that you got sitting on this board. That's pretty much all I have to say.
Bill? Sizer?
Yes, it's Bill Zizer. I work for DMAS, the Virginia Medicaid program. And a couple of things, the last few meetings that we've had, I want to bring up what we do in Virginia as far as containing the broker from making too much profit. We do have a risk corridor built into our contract. And during COVID-19, obviously, it came in very, very handy to prevent the broker from getting paid the PMPM and keeping all the profit. The risk corridor keeps the broker from keeping all the money left over, not utilized out of the PMPM. And we do that a couple of ways. Number one is we require the broker to furnish their quarterly financials, showing how much expenditures they have for their admin, and then obviously for what they say they've spent on transportation costs for the service. But more importantly, we require the broker to submit 100% of all money spent on transportation as encounters. And we have a third-party company outside that's contracted with the state that actually does our risk corridor calculation. And we've been able to get back millions of dollars as an example because of a lack of using transportation because of COVID-19 and shutting down the majority of our service centers places for our people with disabilities. The other couple of things that we do is we have a lot of service level agreements that try to keep the broker from not doing what he's supposed to by supplying everybody trips. We have SLAs for not providing services for the number of trips they furnish, hospital discharges, they need to do 95% of those. An additional one would be for every discharge over 3 hours, we actually charge the broker $5,000 per hour. Just to give you an example of some of the SLAs that we do put against the broker for not furnishing the services that they're supposed to. In order to transport people with disabilities, we also have what we call an attendant that we put on the vehicle. And if the member needs somebody to watch them while they're sitting in the back of the vehicle because of behavioral issues, we have a process in place to get the broker to make sure that that provider supplies that attendant for when they're in the vehicle. We also, since 2018, have been utilizing TNCs. I put in place two different types. Type 1 would be an Uber and Lyft. The second one is we actually have TNCs who have qualified past trained drivers that are actually in a TNC and they do trips as well. We utilize TNCs as a provider of last resort, and we actually audit the broker to make sure that they've actually offered these trips to actual providers before they're actually put onto the TNC. In order for a person with disability to ride with the TNC, we have to get the caregiver and the case manager, as well as the person at the facility, to approve that person with a disability to ride with the TNC. And we have different, also other rules, like they need to be able to understand what a smartphone is and how to be able to utilize it. To help with the ambulance situation, state of Virginia, we've worked with our EMS agency, state agency, and we have stretcher vans. I've been utilizing them for almost 17 years here in the state. But again, our brokerage is over 20 years old, and we have all those problems that I've heard in the last 3 meetings, but we've been able to work with the broker and be able to overcome the challenges that do come up with the broker model. Thank you for letting me make these comments.
Bill?
Dawn, do we have anybody in the queue?
No hands up.
Okay, thank you. So I think what we'll
Now
do,
now a couple
Yeah.
hands went up now.
all I have to do is speak. So I'll be quiet and let people have the floor. Thank you.
Dan Reed.
Yes, hi, this is Dan Reed. And I would just like to say first, I applaud the efforts of the last speaker. I believe that was from the state of Virginia, and the processes and protocols they've put in place to deal with the inherent conflict of interest that is in the broker model. And I want to stress that just because there is an opportunity for a conflict of interest doesn't mean that a conflict of interest exists, any more than saying that an industry is at high risk for fraud, waste, and abuse means that there actually is fraud, waste, and abuse in that industry. However, when you do have a appearance of a conflict of interest, it is absolutely critical that you do everything you can in place to make sure that you show that conflict of interest does not exist. And so some of the things that I believe he mentioned and the things that are, I believe, important for the NEMT industry would be having brokers be required to disclose exactly how their revenues are allocated between internal costs, general administration, and payments to providers. Disclosing how their algorithms weigh the various factors in terms of allocating trips, including quality, price of trips. Disclosing how they rate their providers for purposes of getting those trips, disclosing how they take steps to ensure that the data they send to providers is accurate, and the steps that they take and have in place to correct any information that comes out that's incorrect, to show that all steps are being taken to make sure that the provider gets the accurate information and the trip is performed. And again, I do want to stress that, just because there is a conflict of interest doesn't mean that there actually is a conflict of interest just because there's an appearance. But if you don't have the steps in place that show that you're doing everything you can to control that conflict of interest, then that appearance becomes reality, and that is something that needs to be avoided. Sounds like Virginia has taken some great steps in that progress, and I think all steps should be encouraged, if not required, to follow many of those same steps. Again, thank you very much.
Andrea.
Thank you. With regard to recurrent scheduled non-emergency transportation, such as our clients going to substance use disorder or medication assisted treatment, our clients who have other scheduled appointments that are in excess of what we would see from the occasional use. We often encounter with those who feel so comfortable on the vehicles. Those are typically where we might run into our unruly participants or our participants who are really encroaching on the rights of others on the vehicle. And when CMS has not given us a mechanism by which we can refuse transportation when somebody imposes on those other individuals' rights to safe, non-harassed, and an environment where there's no potential criminal activity taking place, we do run into conflicts where we can't not take them, but they're really not appropriate for a public vehicle because of activities or actions while on the vehicle. So I would like to see CMS issue some type of guidance for how to handle unruly or unlawful participants, or to reframe that into a way where we can deal with conflict in a confined and potentially high danger environment, similar to the way that other transportation entities such as airlines and rail have taken into account what happens when somebody else's rights are violated by the actions of a consumer. Thank you.
Travis.
Yeah, thank you for the opportunity. Just to second some of the problems and issues that we've talked about, selecting the appropriate level of service. For transporting patients, there's such a broad understanding, from ride shares to wheelchairs to gurney vehicles to ambulances, BLS, ALS. And the distinguishing line between the different levels of service can become a little gray. And we've seen an issue, and I've heard some of our providers throughout the United States where they've talked about how a lot of times it goes to the lowest paying option, whether it's a ride share or whether it's a wheelchair, where the patient or member may more appropriately need something like a gurney or even AMS or ALS or BLS level of service. So it would be great to have some type of better understanding, instead of the lowest common denominator, the lowest payer, to be more of the appropriate level of service. And I think those costs can break down in a few different ways, because when we are transporting a patient that really needs a wheelchair, and they're going through a ride share, if that's going to introduce more risk of that individual patient falling or tripping to the vehicle, that's risk to the member and that's risk to the provider. And some of those insurance rates that many providers are facing throughout the United States are skyrocketing because of those different types of risks. So just thinking about reterming that to the more appropriate level of service than the least paying service. There's other resources out there compared to standard wheelchairs being transported in, where it's a standard and not a law, where wearing a seatbelt is a law, being in an infant car seat is a law, but being in a standard wheelchair is a standard. Gurneys are crash tested, but now we have WC19 crash tested wheelchairs. It's tricky to navigate ADA and whether that patient, whether that member or passenger, whether that's their chair or whether the provider is providing the chair. Different things like that can help mitigate some of that risk when we're talking about the appropriate level of service. Thank you for your time.
So it appears that our queue is now empty. What I will do is scroll through, I'll read off the subtopics. And if anybody has any further comment on any of the subtopics, please raise their hand. So the first of the subtopics is transportation related expenses and direct payments. The second subtopic, meals, lodging, and payment for an attendant. The third subtopic, transportation for beneficiaries with challenging behaviors. Fourth subtopic, direct payments to beneficiaries, family, and volunteer drivers. It looks like we have one comment.
It's Bill Zeeser from Virginia again. On meals, lodging, and payments for attendants or to families, prior to managed care coming to Virginia, we did around 250 out-of-state trips with our children that couldn't get treatment with inside the state, going to out-of-state to Children's Hospital in Philadelphia or Cincinnati. We used the GSA limits for meals and lodging, and we paid them directly to the family if our Medicaid medical review department approved their treatment out of state. And this worked really well by paying the GSA rates. And we had the forms put together and sent to the families, and all the paperwork was submitted back to us for reimbursement out of the state funds. The brokers, we currently have 4 brokers in state, and if there's any travel to be done in state, which we have a very large geographic state, and if the members had to spend the night, those families would receive reimbursement from the broker. But again, the service had to be pre-approved before the member could actually get to those places. At times, we did have providers that would, with pre-approval, would actually pay for the member's hotel room because the family didn't have money. And those arrangements were worked out ahead of time with the providers that are willing to do that. Again, I get back to the challenges with people with the behaviors. Again, everybody understands how challenging that can be, but we have a lot of providers that do have additional training through our CSBs and things that will are able to help with that behavior on those vehicles. And of course, like I stated before, about having the attendants on the vehicles really helps if you have a member that is very unruly or likes to put their hands on other people while they're being transported. But again, thank you.
And it looks like we have one more hand. We had a hand raised and it's back. We have a couple. Devon, do you want to call on those with their hands raised?
Okay, Bill? Oh, you took your hand down.
I know one office was called.
It looks like we have.
Okay, Bobby? Yeah, you've got two mics on, so you need to turn one of your mics off.
How about that?
Nope, you still got one of them on.
Okay, I'm trying to find the mic.
You have, did you call in or dial in? You can call us back or put your hand back up later.
Okay, I will continue to read through the subtopics. So direct payments to beneficiaries, family, and volunteer drivers. Broker conflict of interest. Broker prohibition on providing transportation. So if there are any further comments on any of those subtopics or any topics related to NEMT, we still have a few minutes remaining on the call. So we'll pause here for a minute or so and see if we have any additional hands raised.
Okay, Bill.
Again, this Bill Zeser, Virginia. We actually have written in our contract at times where a broker is prohibited from doing internal transportation or providing any transportation whatsoever to any of the members, or no backup plan. We do have a couple of brokers in the state for MCOs, and they have the same language built into their contract as well. And if they do want to try it, because of COVID-19, there's been one instance where a broker came to us asking if they could put some vehicles on the road because of the lack of drivers or providers. We've lost like 40 providers in the state right now because of COVID. And in order to make sure Medicaid members covered their transportation, one broker did ask if they could put a few vehicles on the road in the rural areas to make sure the members did get their transports. But again, I think it's important that it's transparent, that the brokers are, communicating with the MCOs or with the state that that's what they're trying to do if it is prohibited in the contract. The other thing I failed to mention on monitoring the brokers, to make sure that we have access into their system through Tableau, and we can actually monitor the trips in the system from the day before and all the weeks or months, years before that. We can actually pull it up by member, by facility, by provider, by dates of service, by level of the service, and we can monitor their trips right into their system without asking for ad hoc reports as it used to be in prior years. So again, we do have monitoring in place to make sure that we are, keeping track of what's going on behind the scenes with the broker. Thank you.
Thank you. And again, we'll pause for another 30 seconds or so and see if anybody else on the call would like to raise their hand and offer comment or put a comment in the chat. Okay, looks like we have one.
Gail?
Hello, this is Gail Nels in the Colorado Springs area. I manage a not-for-profit that works with transportation and home care. We are currently almost developing a brokerage model on a regional transportation basis with other nonprofits in the area. So we would be advocating for regional brokerages around the NEMT, as well as allowing us as a provider to also be the broker. We're very familiar with the needs of the community and the people we are serving. We are unable to meet the demands of that, whereas in the past, we have seen the statewide brokerage fall apart here in Colorado. We think that was due to the lack of knowledge of the local communities and the needs of those communities. So I would like to look at a waiver for broker being allowed to provide transportation. As we are a not-for-profit, our books are all open and can be audited at any time.
Great, thank you. And we'll pause again for a few more seconds to see if there are any other, anybody else on the call that would like to raise their hand and offer comment. Okay, this brings us to the conclusion of today's listening session and to the conclusion of our series of 4 listening sessions on NEMT. We thank everybody who participated in today's session, as well as the other sessions that were part of the series. As a reminder, today's session was recorded for note take, was recorded. And if you have any additional comments that you were unable to share today, or prepared comments that you did share today, please feel free to email them to nemtengagement@miter.org. And again, that will be put into the chat. CMS will take all of your input into consideration. We truly appreciate you joining us for the final NEMT listening session today and for providing this valuable feedback through your comments. Again, thank you. And this will be the conclusion of today's call.